Thank you again. Shall we? Yeah. Okay. Thank you again. And I'll be presenting a 13-year-old male who is a national level skating champion, as well as does a lot of athletics, both mid-range as well as short-range running. He's injured his right knee about 3 months ago, has got recurrent buckling and swelling, and of course desires to play. The whole family also wants him to compete at a higher level. On clinical exam, at the end of 3 months, the range of motion is 10 degrees of hyperextension, 240 degrees of flexion, a grade 2 pivot, a grade 2 soft pivot glide, as well as a grade 2 latchman. Collaterals are normal, patella is normal, there's minimal effusion, and his gait pattern is normal. So these are the MR scans which we have. They've been done a month ago, and you can see that there's an ACL rupture right there, and there is also a tear of the lateral meniscus. Obviously, at the age of 13, the physeal plates are open. Any more information that you need? Anybody wants any other information? Sorry? So, okay, so he's not hyperlax. I have not put down the Byton score, but he's not hyperlax. Okay, so he's got 10 degrees of hyperextension, but that's fine. Yes, Raju?
Do you like to do a blood profile, the serum biochemistries and bone aging, elbow x-rays, etc. in such pediatric cases for assessment of growth remaining?
Yeah, so Tanner staging, yes. So he was a Tanner stage 2, stage 3. Blood profile, I'm not so sure. What is the reason to?
For what? Alkaline phosphatase, vitamin, most of them may be vitamin D deficient.
Would that have bearing on our treatment plan?
Since we are considering working around the physes, regardless of whether we do physeal sparing or transphyseal, just a basic metabolic workup,
okay.
PTH levels, alkaline phosphatase, calcium, phosphorus levels.
Okay.
And if they are deranged, then deferring surgery till the time they are normalized, maybe an endocrinology referral.
How would that, educate me on that. This is new to me.
So the reason is, this is the protocol I follow for all my pediatric ACL reconstructions. A lot of us a lot of us sitting in this hall may be vitamin D deficient, and we may have a secondary hyperparathyroidism. Now that may cause a physeal growth disturbance in itself. So just to normalize the metabolic profile is something that I would like to do before undertaking anything surgical on a kid.
So is this specific for children or
only
for
children?
Everyone?
No, children.
Okay, so
with growth remaining.
New for me. I didn't know that it has a positive influence on.
And even assessment of growth remaining. I always send them to Correct. A pediatric endocrinologist. They do this Grulich and Pyle, Lackles, and I don't understand what exactly they do, but then they tell you what is the assessment of growth remaining.
And how will that influence your decision?
So if the assessment of, we have a lot of 13-year-olds who have growth of 15 years olds. We have a lot of 13-year-olds who have a lot of growth remaining. So one can do a transphyseal reconstruction, a standard ACL reconstruction in a child who doesn't have too much growth remaining.
True. And I think this is very important because not all kids are little men. You can't treat them like little men. And it's not uncommon to see, if you just put on your TV channel and try and start watching kids soccer, you'll find, or even any sport for that matter, if you look at the under 15 team, some of them look like 18 years old, some of them look like 9 years old or 10 years old, and they all may be the same chronological age, but physiologically they'll be different. And that's why looking at growth charts, looking at Tanner staging, and the parents, of course, is very important and critical. So that brings us to our first ARS question. Assuming that we would want to look at surgical treatment, what is the youngest age if you have a patient with an ACL deficient knee that you would advise surgery? So it's good to hear that age is not a cutoff in this room, and I think this is probably the biggest challenge, at least which I face in my clinical practice, because all my orthopedic peers who are not as enlightened as all of you always tell all these kids that, oh, don't do surgery till you're 14 or 16, continue a brace, because brace never work for kids. Braces are not prepared for children. Show me an orthopedic company who prepares braces for kids, and even if you give a knee brace to a kid will never wear it. So I don't think there is a lot of role of conservative or non-operative treatment. And the other important aspect is that this paper that got published in the core, looked at what is called as a child opportunity index. And people or kids who did not have adequate opportunities in terms of education, socioeconomic strata, they had extremely higher rates of delayed ACL reconstruction, delayed non-operative treatment, and we are not only talking about the opportunity in terms of social economic strata, or it's all about education and understanding. So if you're working in an area where your orthopedic peers are not that aware, the child opportunity index drops. So I think that's important. And we know that, when we treat kids, we can have a variety of treatment, especially with open physes. You can do your transphyseal method where you cross the physes, and of course you will fix it away from the physis with suspensory fixation. So that's a transphyseal method. Or you have the physeal sparing methods. There are two of them. This is the Kocher method, in which you harvest a strip of the iliotibial band about 25 centimeters long. You leave it attached distal to the Gerdes, and then you take it at the over the top position. And once you've taken it over the top position, you bring it inside the joint. You route it underneath the intermeniscal ligament, so no bone tunnels drilled, and then you suture it down to the periosteum on the anteromedial tibia. Or you can make tunnels, and when you prepare tunnels, you can do an all epiphyseal tunnel which spares the physes on the femur as well as on the tibia right there, and you would want to fix it with suspensory fixation devices which are away from the physeal plate. Or you have the hybrid, where you do all epiphyseal tunnel in the femur and you cross the physis in the tibia and fix it in this particular manner here, like this. So for this 12 to 13-year-old kid who is a Tanner stage 2, stage 3, what treatment will you do? ARS question 2. Are you going to do the Mininder Kocher Micheli technique, which is physeal sparing without tunnels? Are you going to do all epiphyseal tunnels? Are you going to do a hybrid technique either on the femur or the tibia? Or you say, I'm just going to do an adult-like reconstruction? Okay, so about 44% feel that they would like to do an all epiphyseal ACL tunnel, and 32% feel that they will spare the physis on the femur and go transphyseal on the tibia. And interestingly, 12% would not really care if this is a Tanner stage 2, they're just going to do an adult physeal. So that's great data. Okay, so let's see what this kid's arthroscopy looked like. So that was what we found in the intercondylar notch, a large torn fragment of his ACL with good meniscus tissue, and obviously with this very large fragment, it was impinging. And I was really surprised that in spite of having a cyclops, this kid actually had hyperextension. So that was something which really did not fit with my preoperative plan, but probably it was flipping inside the notch during extension. So this was the ACL footprint after I took down the torn ACL fibers. And I feel this is really important because when we are trying to drill tunnels in children, we keep on feeling that we should put the smallest tunnel, but it's really not so. You can see that even in a 13-year-old kid, the width is around 7 millimeters and the length is almost 12 to 13 millimeters. So be surprised, children do have significant ACL footprints, and one of the reasons where one can go wrong is that we treat them differently and we feel that we should put in a very small graft. Obviously, the medial meniscus was normal. You want to check for any ramp lesions, lesions of the posterior medial side of the knee. You want to check for the medial meniscus per se. You want to ensure that there are no meniscus tears, which is very critical and important. And he had a tear of the lateral meniscus as we had expected when we read his MR scan. And this was a tear on the undersurface. You can see that dimpling effect. And that's a tear probably in zone 1, zone 2, which is an undersurface tear. And obviously we know that through good data that these undersurface lesions of the lateral meniscus, if you leave them alone, they will progress, and over 40% of them will become full tears in a matter of about 12 to 16 months. So obviously you want to go ahead and repair them with any of the all-inside devices. This is a flex device, and then you want to close this meniscus tear down, repair it only from the undersurface with a curved needle. Do not come on top, which helps sort out that aspect. Graft choice. We know, yes, Raju.
In fact, my question was based on that. So you showed a very wide ACL footprint.
Correct.
Now in adults, we have published data, but what do you do? How do you decide for a kid? 4-strand, 8-strand, 6-strand? And the second question is, what is your opinion on sockets instead of tunnels in pediatric ACL reconstruction?
Perfect. So we'll come to the socket part later. We'll all agree that we want to use a soft tissue graft. We do not want to use a bone plug for sure. So the graft choice will have to be either a hamstring or a quad tendon. Now, what sort of graft will you use, Raju? So it's very nice that for every 1 centimeter increase in height, your predictive increase of the semity is going to be by 0.2 centimeters and gracilis by 0.15. So about 75% of patients will be able to achieve a 4-strand semity graft of 8 millimeters, which is why don't harvest the graft first, especially if you're dealing with a kid. Measure the footprint. So now in this patient, I know that I want a graft of 7 millimeters diameter. I do not want an 8 or a 6 or a 5. So I will first harvest only the semity, triple it, check the diameter, quadruple it, check the diameter, and of course check the length. And based on that, make a decision whether I want to harvest the gracilis or whether I can preserve it. Also, the other good thing you can do is that you can also harvest a quad tendon graft, which you can tailor make depending upon what you require. And there is no difference between the patient reported outcomes, failure rates, and laxity if you use it as a primary or as a secondary source. So fine tune your graft to the patient and not the other way around. How do you drill your tunnels? So obviously you can do sockets or you can do tunnels depending upon what you're comfortable with. What is important and critical to remember is that the physeal plate on the femur is not a straight line. It is more proximal proximally it is higher and it dips down distally in the center, and that is what you need to remember. And what is also very critical is that if you are making an outside in tunnel or if you're going over the top, you need to protect the perichondrial ring because that is where maximum growth takes place. And this relationship is very important because if you're planning to drill either on the femur or on the tibia, and if you drill sockets or tunnels, on the tibia, if you cross the physes, you are likely to compromise the physes by about 6 to 8, less than 6%. And on the femur, you are likely to compromise it by less than 2%. So unless you're completely off, you will be in a problem situation. And on the femoral side, if you drill a vertical transtibial tunnel, it is safest for the physis, but remember these children have very high velocity injuries, which means that they require a good, stable, robust ACL reconstruction, and placing a very vertical graft as in a standard transtibial technique, though it is good for the physis, is bad for the ACL stability. If you do a transportal like what we do for an adult, that is extremely bad for the physis, but good for the ACL because the trajectory is such that it will cause maximum violation of the physis. So in my hands, the best way to drill it is to drill it outside in because it is safe for the physis, but yet gives you that anatomical point on the femur, which will then allow you to have a good ACL reconstruction and a robust ACL graft. But of course, you need to make a decent exposure on the lateral side. You have to be safe with the insertion points of the FCL and the popliteus and then go ahead. So that's answering about that. The failure rates, if you do a transtibial or if you do outside in or inside out, are comparable. But as we said, if you do independent drilling, which is adult like transportal or an outside in, you have far better outcomes in terms of laxity, proms, which is very important and critical. So you can take a simple PCL femoral jig after you've made an incision on the lateral side. Please don't try and do this as an MIS surgery by making a small puncture hole. And you want to ensure that your exit point, you can preserve all that stump and you can do a good outside in drilling for the femoral side, either by making a blind socket as what Raju prefers, or by making a tunnel if you're not too well versed with all these retro cutting devices. This is probably the important way to do it. You need to have this kind of a setup. So this is what my setup is. You need to have an image intensifier which comes in from the same side, and you need to check it both in AP and lateral to ensure that you're not violating the physeal plate, and yet at the same time ensure that you are able to visualize it as well. So you need two eyes, one eye on the image and one eye on the monitor, and you want to bring your guide pin in. You need to get an image check, and you want to check it not only in the AP but in the lateral as well. And then you want to come in progressively, take progressive serial X-rays as you go ahead while drilling your tunnel. Keep one eye on the arthroscopic view, keep one eye on the image intensifier, and then once you're in the notch, you can confirm by putting a scope in your tunnel that you have not violated the physeal plate.